Let me tell you about a woman named Eleanor. Eleanor was 76 years old. She was healthy. She walked 3 miles every morning. She had just finished reading a novel a week for the entire winter. Her grandchildren said she was the sharpest person they knew. She went in for her annual checkup. She felt fine. Her doctor looked at her chart and said the words that millions of seniors hear every single year. You're due for a few routine tests, just to be safe. Eleanor was a polite woman. She trusted her doctor. She agreed. 6 weeks later, Eleanor was in a hospital bed, recovering from a surgery she did not need for a condition that was never going to harm her, that was discovered by a test she should have never taken. The woman who walked 3 miles every morning has not walked unassisted since. Eleanor's story is not rare. It is not a tragedy of bad luck. It is the predictable result of a medical system that runs on autopilot and treats a 76-year-old body the same way it treats a 46-year-old body. I'm here today to tell you exactly why that math is wrong and to walk you through 5 specific medical tests that, after the age of 65, can quietly start a chain reaction that ends the independent life you've spent decades building. My name is Dr. Goodman. For years, I've been digging through the medical literature, the studies most doctors don't have time to read between back-to-back appointments, and translating what the evidence actually shows into plain language seniors can use. What I'm about to share with you is not anti-medicine. I believe in medicine. I have seen it save lives. But there is a difference between medicine that helps you live well and medicine that simply finds things. After 65, that difference becomes the most important thing in your healthcare. By the end of this video, you'll know the 5 tests I would personally think twice about after 65. You'll understand the science behind why each one becomes more dangerous as we age. And I'll give you a simple set of 5 questions, write them down, that will completely change how your next doctor's appointment goes. Stay with me all the way through, because number 3 is the test almost every senior has agreed to without thinking, and the data on it has stopped cardiologists in their tracks. And number 1 is the one almost nobody is talking about. It's been quietly removing seniors from independent living for years, and most of them never saw it coming. Before we begin, I'd love to know where you're watching from today. Drop your city or country in the comments below. I read every single one, and it genuinely helps me see who I'm speaking to. So pause and let me know. Now, before I name the first test, I have to give you one concept, because without it, the rest of this video won't fully land. I call it the longevity math. When you're 45 or 50, screening medicine is beautiful. Catch a problem early, treat it, buy yourself 30 more years of healthy life. The math is clean. The investment is worth it. But after 65, 3 things change at the same time, and almost no one in the medical system stops to recalculate. First, many of the things that routine screening finds in older adults were never going to harm you. They grow slowly, they cause no symptoms. Your body would have lived alongside them for the rest of your natural life without trouble. But the moment a test puts that finding on a page, medicine doesn't have a leave it alone button, it has a treat it button. Second, your body's tolerance for medical intervention drops significantly after 65. The same procedure a 50-year-old recovers from in 2 weeks can take a 75-year-old 6 months, if they recover at all. And third, there's what doctors call the cascade effect. One test finds one small abnormality. That triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And suddenly, a person who walked in feeling completely healthy is in the middle of a medical nightmare they never asked for. That's the longevity math. Hold it in your mind as we go. Test number 5. Routine colonoscopy after age 75. Let me tell you about Dorothy. Dorothy was 78, a retired school teacher from northern Michigan. She had 2 clean colonoscopies in her 50s and 60s, no family history, no symptoms, nothing in her body suggesting concern. But her new doctor looked at the calendar and said, She was due. Dorothy did not want to be difficult. She agreed. The bowel preparation, that liquid you drink the night before to clear your system, hit her kidneys hard. By the next morning, she was confused, dizzy, and barely able to stand. Her son drove her to the emergency room before she ever made it to the procedure. She had become severely dehydrated. Her electrolytes were dangerously low. Her heart rhythm became unstable. Dorothy spent 5 days in the hospital. She never had the colonoscopy. And here's the part that should make you angry. She didn't need it. The United States Preventive Services Task Force, the gold standard body that sets screening guidelines in this country, officially recommends against routine colonoscopy in average-risk adults over the age of 75. The evidence is clear. After 75, in a person with no symptoms and no family history, the risks begin to outweigh the rewards. Bowel perforation, a literal tear in the colon, occurs in roughly 1 out of every 500 colonoscopies. In a younger adult, that's a manageable surgical complication. In a 78-year-old, it can mean emergency surgery, a colostomy bag, weeks of hospitalization, and a recovery that fundamentally changes what your life looks like afterward. Meanwhile, the colon cancers most likely to be found in older adults who have no symptoms tend to grow slowly enough that in many cases they would never become a problem in the years a person has left. What to do instead? Ask your doctor about a non-invasive stool-based test. Products like Cologuard or an annual FIT test can flag real warning signs without the procedural risk. And if you do have symptoms, blood in your stool, sudden changes in your bowel habits, that changes the equation entirely. See your doctor. Test number 4. Aggressive cancer screening, PSA and mammography for low-risk patients after 75. Now, I need to be very careful here because this topic deserves precision. I am not telling you to stop screening for cancer. Cancer screening has saved millions of lives. It may save yours. What I am telling you is this. After the age of 65, in average-risk adults with no symptoms, aggressive cancer screening has a serious overdiagnosis problem. Here's what overdiagnosis means in plain English. Imaging technology today is so sensitive that it picks up cancers that are biologically almost asleep. Tiny, slow-growing tumors that, left untouched, would never spread, never cause a symptom, and never shorten your life. You would die with them, not from them. But the moment the word malignancy appears on a report, the medical machine engages. Biopsies, specialist visits, surgery, radiation, all of it moves forward, regardless of whether that cancer was ever going to be the thing that took you. A landmark analysis published in the New England Journal of Medicine found that a significant portion of cancers detected by mammography in women over 70 were clinically insignificant, meaning treatment provided no survival benefit, only side effects. Think of a man named Richard, 79 years old, sharp, independent, still fishing every Saturday. Routine PSA came back mildly elevated. Biopsy found a slow, low-grade prostate cancer. His urologist recommended radiation. Richard trusted him. Within a year, Richard was dealing with chronic fatigue, urinary problems, and a daily quality of life that had dropped so dramatically he stopped going fishing altogether. Stories like Richard's are documented across the medical literature. Men who, in hindsight, wish someone had told them their cancer was the kind they would have lived alongside, not died from. What to do instead? Have an honest conversation with your doctor. Ask the question almost no one asks. If we find something, what are the realistic treatment options for someone my age? And what would the impact on my daily life actually be? That single question changes the entire dynamic of the appointment. If you're still with me and learning something useful, do me a favor. Type the number 2 in the comments below. It tells me this is reaching the right people, and it gently pokes YouTube to put this in front of one more senior who needs to hear it. Test number 3. Routine cardiac stress testing in seniors with no symptoms. This one surprises people because it sounds so reasonable. Your doctor says, "You're 72. Let's just make sure your heart is in good shape." You walk on a treadmill, or they inject a medication that mimics exertion, and they watch your heart respond. Sounds harmless. Sounds responsible. Here's the problem. In adults over 65 with no symptoms, cardiac stress tests have false positive rates that can reach 40% or higher. That means almost half the time the test flags something abnormal when the heart is actually fine. But medicine cannot shrug at an abnormal finding. That false alarm launches you into the next phase, a cardiac catheterization. A thin tube is threaded through your blood vessels, usually from your wrist or your groin, directly into your heart. It is a real procedure. The risks are real: bleeding, vessel damage, arrhythmia, and in rare cases, the procedure itself can trigger the very heart attack or stroke it was meant to prevent. And here's where it gets worse. If the catheterization finds a partial blockage, which is extremely common in seniors, most of whom have no symptoms at all, many doctors will recommend placing a cardiac stent. Multiple landmark trials, including the widely cited ischemia trial published in the New England Journal of Medicine, have shown that stenting in patients with stable coronary disease does not reduce heart attacks and does not extend life, compared to managing the same patient with medication and lifestyle alone. Let me say that again. The stent did not help, but it carried real surgical risks of its own and locked the patient into a lifetime of blood thinners with their own bleeding complications. So you've gone from feeling fine to a routine stress test, to a false alarm, to a catheterization, to a stent, to a lifetime of medication. And statistically, you are not one day safer than the person who walked 30 minutes a day and managed their cholesterol with a pill. What to do instead? If you have no chest pain, no unexplained shortness of breath, no dizziness during activity, routine stress testing is searching for problems where treatment hasn't been shown to help. Talk to your doctor about the things that actually move the needle: blood pressure, cholesterol, blood sugar, daily movement, sleep. Those are where the real gains live. Test number 2. Routine bone density scans leading to automatic medication. Here's how the pipeline usually works. You get a DEXA scan. It shows low bone density. You're prescribed a bisphosphonate, medications like alendronate or risedronate. You take them for years. You assume you're protected. Here's how the pipeline usually works. You get a DEXA scan. It shows low bone density. You're prescribed a bisphosphonate, medications like alendronate or risedronate. You take them for years. You assume you're protected. But what doesn't usually get mentioned in that appointment is this. Long-term bisphosphonate use is associated with a rare but serious condition called atypical femoral fractures, spontaneous stress fractures in the thigh bone, the very bone the medication was meant to protect. These fractures can be severe and often require surgery. The same medications are also linked to osteonecrosis of the jaw, a painful deterioration of jawbone that is extremely difficult to treat once it begins. Meanwhile, the most effective intervention for preventing fractures in older adults, bar none, is not a pill. It is fall prevention. Studies show that Tai Chi specifically reduces fall risk by nearly 50%, removing tripping hazards from the home, installing grab bars, checking for medications that cause dizziness, getting your vision rechecked every year, making sure your diet has enough protein and vitamin D. These interventions reduce fracture risk more meaningfully than any pill. I am not saying never take medication for bone health. There are patients who absolutely need it. Those who have already had a fracture, those with very low T-scores, those with specific risk factors. But a routine scan leading to an automatic decade of medication? That's a conversation. What to ask your doctor? Before we talk about medication, can we review my fall risk factors? And what is the actual fracture risk reduction from this drug compared to a structured fall prevention program? Now we come to the test I told you about at the beginning, the one almost no one talks about. the one that has, quietly, year after year, moved seniors out of their own homes and into care facilities. Most of them never saw it coming because the test itself felt so harmless. Test number 1. Routine carotid artery ultrasound in seniors with no symptoms. A carotid ultrasound checks the large blood vessels in your neck, the ones that carry blood to your brain. The premise sounds completely reasonable. If we find a serious blockage, we can fix it, and we can lower your stroke risk. Logical, right? The reality is far more dangerous than that, especially in seniors with no symptoms. Here is the key fact almost no one will explain to you in the room. The surgical procedure used to treat a carotid blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after the surgery itself. In older adults with other health conditions, that risk goes higher. The United States Preventive Services Task Force explicitly recommends against routine carotid screening in adults who have no symptoms, no mini strokes, no sudden vision loss, no neurological warning signs. Their analysis was clear. In asymptomatic seniors, the risk of surgical harm outweighs the benefit. Here's why. Many seniors have some degree of narrowing in their carotid arteries. That narrowing has often been there for years, stable, silent, causing no problem. When you screen for it routinely, you find it. A well-meaning surgeon then recommends fixing it. But the very act of operating to fix a blockage that was never causing symptoms can sometimes dislodge a piece of plaque, sending it directly to the brain. A senior walks into a screening appointment feeling completely healthy and leaves on a trajectory she never could have imagined. Not because of the blockage that was found, but because of the intervention that followed. What to do instead? If you have no symptoms, no sudden vision changes, no facial drooping, no arm weakness, routine carotid ultrasound is generally not the right tool. Put your energy into controlling the things that actually drive stroke risk. Blood pressure, the single biggest factor, blood sugar, smoking, atrial fibrillation, and staying physically active. And if you do experience any neurological symptom, even one that fades, get evaluated immediately. This tells you how likely the test is to trigger unnecessary follow-ups, even if nothing is wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? This forces the conversation toward outcomes, not just findings. Question 1. What is the false positive rate of this test in someone my age? This tells you how likely the test is to trigger unnecessary follow-ups, even if nothing is wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? Question 3. What is the procedural risk of any treatment we'd likely pursue? Every procedure has risk. You deserve to know it before you agree to the test. Question 4. What happens if we monitor this instead of treating it? For many conditions found in older adults, watchful waiting is a legitimate and often superior option. Question 5. What's the most effective non-invasive intervention for this condition? Because very often, lifestyle and medication outperform procedural intervention with far less risk. Any good physician will welcome these questions. They will respect you more for asking them. And if your doctor dismisses you or makes you feel difficult for raising them, that's important information about whether that doctor is the right fit for you. I want to leave you with this. There is a difference between medicine that finds things and medicine that helps you live well. After 65, the goal of your healthcare is no longer to generate findings. It is to protect what you've already built: your independence, your energy, your ability to walk 3 miles in the morning, to read a novel a week, to be present for your grandchildren. The best physicians I know understand something most of the system has forgotten, that doing less at the right moment takes more wisdom than doing more. That recommending watchful waiting takes more courage than ordering another scan. You have the right to know what a test is looking for. You have the right to know what happens if something is found. You have the right to ask whether a finding would actually be treated. You are not a checklist. You are a person, and you deserve a healthcare experience built around your goals, not the system's defaults. If this video gave you a new way to think about your health after 65, please subscribe. I make videos like this every week. And leave a comment below. Have you ever had a routine test that led somewhere you didn't expect? Your experience may be exactly what someone else needs to hear before their next appointment. Take care of yourselves. I'll see you in the next one.